Hi, how's it going? My name is Dr. Sivasundaram. I'm an orthopedic surgeon who specializes in shoulder, hip, and knee surgery. And the purpose of my talk today is to talk about hip impingement, FAI, and what is hip arthroscopy. And so the idea of this talk is for it to be more of a comprehensive talk on what FAI is, what a labrum tear is, and kind of what we can do arthroscopically to preserve the hip. So a little bit about me. I'm fellowship trained in shoulder, hip, and knee surgery. I treat a variety of pathology, but the primary focus of my clinical practice in the Simi Valley, Thousand Oaks area is shoulder, hip, and knee surgery. In some prior experience, I helped take care of the Cleveland Browns. Did have some experience with the Chicago Bulls, the Chicago White Sox, and the Chicago Fire as well. And I'm currently also the current team doctor for Oak Park Athletics. So when we talk about FAI, what is FAI? Well, FAI stands for Femoroacetabular Impingement, and that stands for an abnormal contact between the proximal femur and the acetabulum. And we'll go into a little bit more detail as this talk goes on about what that even means. On the bottom left of this image here, you can see what's a normal hip, and then at the end of this talk, you'll understand what a cam and pincer deformity look like. But this is a cadaveric model here that I'm going to show here before I start playing it, just to get the 50-yard view of what's going on here. This is a cross section of the hip where you see the femoral head on the right and the socket or acetabulum on the left here. And really what you can see here is that the cam deformity is on the superior aspect of the femoral head there. And you can see as that femoral head cam deformity engages onto the labrum, that can cause a labrum tear over time and also can result in instability of the hip. And so really right there is kind of the best example of, this cam impingement. And so again, I'm going to play this here one more time where again you see the cam deformity on the superior aspect of the femoral head there, engaging on the labrum tear right there, and at the end arc of motion, which I think they're going to get to right here, you can see that it does result in hip instability as well, the labrum. A pincer deformity is when there is abnormal bony growth on the acetabulum or the cup side of the hip joint. And that can result in impingement and pain-related symptoms. It goes a little bit further in the weeds here with over coverage of the femoral head, resulting in conditions like coxa profunda or acetabular retroversion. But really, the pincer deformity is often a sequelae of this idea of femoral acetabular impingement. It's seen in about 15 to 30% of the population. Often this FAI can be bilateral, but usually when patients present to my office, they present with one hip that is particularly symptomatic. We see this condition a lot in hockey goalies, gymnasts, and ballet dancers. And the classic patient that I see in the office is a young individual, and left untreated, there's some theories out there, not particularly proven just yet, but there is theories that this can be a major cause of hip arthritis down the road. Patients often present with complaints of groin pain, in particular with long periods of sitting, standing, and hip flexion. Patients often complain of mechanical catching symptoms, and psoas tendinitis or hip flexor tendinitis is the most common associated symptom with it as well. This idea of the Fader exam is probably the most sensitive physical examination maneuver for FAI, and Fader stands for flexion, adduction, and internal rotation of the hip. Standard radiographs can often be normal, and for this reason, this idea of the cam deformity can often be missed, and so you need specialized radiographs such as a done lateral view to truly obtain the cam deformity. A good example of this cam deformity here is on the right-handed X-ray image, where essentially if you picture in your mind's eye what a perfect circle of the femoral head would be, there is a cam deformity on the superior aspect of the femur joint. MR arthrogram is often very sensitive for detecting labral pathology that does involve a injection of dye into the hip joint. On this examination and example here, this is a coronal or AP sequence of the hip. On the left, you can see that there's a hip joint without the dye in the hip, and then on the right, you can see that it's the same hip after some dye has been injected in the hip. And you could see on the where the arrow is there that there is a labrum tear that if the arthrogram test was not obtained, you often would have missed. And so I personally really prefer the MR arthrogram study, specifically for looking at labrum tear in the setting of femoroacetabular impingement. Sometimes CT scans can be obtained as well. And really the CT scan can assist us with preoperative planning. Really it helps me kind of create a 3D representation in my mind of what my plan would be for arthroscopic intervention. And so for select patients with large deformities or concerning acetabular morphology, I often get a CT scan to help better understand their hips. This is also a 3D preoperative planning of the hip. It's called the hip map. It's from one of the proprietary vendors that we utilize. And this is just another way for us to preoperatively plan so that we have as much information as we can utilize when we help treat our patients with FAI syndrome. Non-operative treatment, I would say, is the mainstay of patients with femoroacetabular impingement. If I see people in the office, we often start with non-operative treatment. The first line therapy includes activity modification, physical therapy, anti-inflammatories, and intra-articular injections, whether that includes biologics such as platelet-rich plasma or an intra-articular cortisone injection. And so I'll say for the majority of patients that come to me for an initial evaluation, my preference is always to start with non-operative modalities because they work. You know, the majority of patients who do have FAI and labrum tears don't often need surgery. And so that's for that reason, we really try to emphasize non-operative management as much as we can. Traditionally, before hip arthroscopy was created, the treatment of FAI or shaving the bump would be an open hip dislocation. And so that's basically historically the mainstay, but now we've really moved on to really performing arthroscopic interventions as a more reliable treatment of FAI pathology. So now with the advent of hip arthroscopy, it offers the benefits of reliable pain relief and treating this cam and pincer deformity through a minimally invasive fashion. And so that's why in modern times, the open hip dislocation has really fallen out of favor for the arthroscopic intervention. So, you know, hip arthroscopy is a complex surgery, even though it's done through minimally invasive percutaneous incisions. There's a lot of planning that I do, both preoperatively when I talk to patients in the office, and also kind of intraoperatively. And unfortunately, you know, nowadays we have a lot of tools to help us treat our patients. This here, for example, is just one of the tools that we can use. This is the Stryker Hip Map preoperative planning tool. And really we use every tool that we can to preoperatively understand each patient's hip morphology and create in our mind's eye a 3D representation of their specific anatomy. And that allows us to attack, the pathology intraoperatively as well. This is similarly planning on the femoral side, where we're mapping out the extent of the cam deformity and determining how much resection needs to be performed, intraoperatively. This is a example of kind of the view that I see when I look inside the hip joint. So these are two static arthroscopic images. And just to orient us to the anatomy here, on the right of each image is the femoral head, or commonly known as the ball part of the joint. And then the socket is the acetabulum there. On the top left there, you can see that there's a probe coming in, and you can see the detached labrum there that we will be repairing. We then proceed to using some anchors and suture, that is high strength suture. We proceed to do multiple circumferential loops around the labrum to reattach the labrum back to the socket part of the bone. I'm going to play this cadaveric video again. And this is a really nice video, and I really like to play it because it kind of gives us an idea and gives my patients an idea of what exactly we're doing arthroscopically. And so this is a cadaveric model here of the acetabulum, and so I'm going to start playing this video right now, where the first thing we do is we decorticate the acetabulum with the cylindrical burr. We're right underneath the labrum there, so now we're drilling an anchor into the acetabulum. We're implanting the anchor, and out of that comes two sutures. We're passing the suture around the labrum, proceeding then to arthroscopically tie the labrum to repair it. So here I'll play that one more time so we can kind of hone in on some key parts here. Again, this is that acetabular decortication here. Then we're proceeding with implantation of the labrum anchor, proceeding to pass the repair stitch around the labrum, and then sequentially tying the labrum as well. The next part of the hip arthroscopy procedure is the cam osteoplasty. And what we do there is we use a 5.5 millimeter round burr to restore the femoral head neck offset by essentially resecting that cam lesion. Generally, these cam lesions are about 5 to 7 millimeters deep and about 8 to 12 millimeters wide. And so, that doesn't sound like a lot. It is a game of millimeters, but that's really all that needs to be taken out to fully correct the cam deformity and restore a more spherical femoral head. So this is a arthroscopic video of what I'm seeing when I perform an arthroscopic cam osteoplasty. So again, this is the cylindrical burr that's now on the femoral head, and this is the cam osteoplasty. So we're progressively using fluoroscopic visualization, intraoperatively resecting this cam lesion. And you can see that really it's a small cavity, and it's a 5.5 millimeter burr. And really we're just slowly kind of shaving the bump down to make it more of a round femoral head and neck junction. So resecting that cam, it takes a lot of 3D planning in your mind's eye. And this is where kind of all of that preoperative planning that you're doing kind of comes to full fruition, where again, you can see on the bottom left, if we're just looking at it, arthroscopically, we're not really seeing anything, from the field. It's because it's all done inside and deep in the hip joint arthroscopically. And so really it's putting together our fluoroscopic view, our arthroscopic view, and then all of our preoperative imaging to fully restore and remove that cam deformity. This is arthroscopically looking at the hip, and so on the top three images, you can see that there is a cam deformity, and then on the bottom three images, you can see that the femoral head looks more spherical, and so now we've resected that cam deformity. And the last part of this procedure is we want to close the capsule back down. So part of the way to access the hip capsule is to perform what's called a capsulotomy, where we essentially incise the hip capsule to access the inner joint. And so we always want to try to repair that hip capsule back to restore stability to the hip. Patients often ask, what the typical rehabilitation process is for hip arthroscopy. And, I always tell patients, these are small incisions, but it's not a small surgery, so I would say I do about 40% of the work for recovery in the surgery, and really the latter 60% of surgery, the latter 60% of the rehabilitation process is, with the patient and then working with the therapist for 3 to 6 months. And so really the first 6 weeks, we're emphasizing protecting the joint. And so that involves protecting the capsule, protecting the labrum repair, and that involves wearing, a brace. The following 6 weeks, you're out of the brace, you're out of the crutches, and now you're working on getting your motion back, getting the hip flexion strength back. And then the last, 3 to 6 months, you're not going to the therapist as much. You're doing more of this at home, but really it's returning back to a pre-injury level of function activity at that point. Often in my clinic, I'll often see patients who've previously had hip arthroscopy by outside surgeons, and they continue to have, some residual hip pain. And so when we think of, common causes of postoperative pain following hip arthroscopy, there's a number of causes that we can think of, and I'll briefly kind of go over each one in more detail. One reason for persistent pain after hip arthroscopy can be inadequate cam resection or not resecting enough cam. And so, for example, on this patient here on the right, this was a postoperative radiograph that does demonstrate that there's a residual cam deformity there. So on the superior aspect of the femoral head neck junction, there is some residual cam. And on the left is the after picture where that residual cam has been resected. And so here's another view of a patient who on the left here had residual cam remaining, and then on the right, that residual cam has been resected. On the flip side, you can have this idea of what's called cam over resection, where too much bone is taken, and that can result in instability of the hip. Hip dysplasia is another reason for persistent pain after hip arthroscopy. I'll go over this briefly because, we could do another, 30-minute talk on hip dysplasia alone. But briefly, that is another reason for persistent pain after hip arthroscopy. And lastly, incomplete or re-tear of the capsule of the hip can be another reason for persistent pain and instability after hip arthroscopy. Here on this MRI arthrogram on the right-hand side, you can see with the dye inside the hip, the dye is extravasating outside of the hip capsule. And that can be a reason for, persistent hip pain and instability. So in summary, femoroacetabular impingement is a common and often undiagnosed source of hip pain in young athletes. And hip arthroscopy can be an effective treatment for femoroacetabular impingement. In my opinion, contemporary hip arthroscopy involves a primary labrum repair, an appropriate cam resection, and that's a fine line because, it's very easy to go to cam over resection where you take off too much of the bone, or cam under resection where you don't take off enough bone. And then there's complete capsular closure, and that's results in less instability of the hip. And so ultimately successful, treatment and return to sport for athletes involves, not just me and the patient. It's a multidisciplinary approach. And you have to have a center or a location where you have a comprehensive treatment of hip-related pathology. And that includes pelvic floor rehabilitation for patients that need it, and even non-operative sports colleagues for evaluation of things like sports hernia. I'd like to, thank you for your time and attention. Again, my name is Dr. Sivasundaram, Orthopedic Surgeon, and these are my office locations. I'm primarily in the Simi Valley and Thousand Oaks areas. Thank you.